So I'd like to welcome everybody today listening by webinar and in person in the room. I've had the pleasure of leading our UTI program work over the last several months. But while I'm here to share about this work with you today, I'd really like to acknowledge the many people that came before me and worked hard to move this program to where it is today. Some are in the room, some are listening by webinar, but I'm certainly happy to represent our collective efforts in all of this. So the objectives of the session today is to describe the public health impact associated with the overuse of antibiotics in long-term care, and specifically around asymptomatic bacteriuria. I'm going to describe the unique methodology that we use to create the UTI program for long-term care homes, and I'm going to list 5 of the key target areas of the program that support behavior change. I'll also discuss some of the strategies that we can use to ultimately minimize the antibiotic prescribing. I'll review the findings from our long-term care home pilot and evaluation that took place during and after the program was created, and I'll discuss how the UTI program can be used to make an impact in long-term care homes going forward. So it's important to recognize that there is a public health impact associated with the overuse of antibiotics. Antimicrobial resistance is now a chief threat to our public health and will continue to grow at a rapid speed from what's shown in this diagram as 700,000 drug-resistant infections to 10 million by the year 2050. Our antimicrobial use is attributed to this growing resistance, and I'm sure over the next few days of this conference you'll hear many different efforts and view sessions and posters and efforts in tackling this area. And we know that there's a variety of healthcare settings that we're setting our efforts into, and the one I'm going to describe today is specifically long-term care. So the UTI program that I am going to talk about, or am starting to talk about, was developed as a response to concerns from long-term care homes in Ontario about the misuse and overuse of antibiotics for presumed UTIs and about the associated antibiotic-related harms that could result. This infographic demonstrates findings that 50% of antibiotic courses are often unnecessary, and 78% of residents in long-term care homes receive at least one antibiotic course each year. Antibiotics can be variably prescribed, and the duration of therapy has been found to be longer than necessary. And we know that antibiotics aren't harmless, and overuse can contribute to Clostridium difficile infections, antibiotic-resistant organisms, and decreasing effectiveness of really important treatment options that we need to preserve. This infographic can be found on our PHO website as part of our Antimicrobial Stewardship Program resources. So in long-term care homes, urine cultures are often sent for non-urinary tract infection reasons. And sometimes residents with a positive urine culture and no symptoms, asymptomatic bacteria, are treated. So asymptomatic bacteria, that can be defined as the presence of bacteria in the urine. And when that can result with the absence of clinical signs and symptoms of a UTI, and unfortunately antibiotics can be prescribed for this. And asymptomatic bacteriuria is quite common. 15 to 30% of men and 25 to 50% of women in long-term care will have some bacteria in their urine. It doesn't require treatment because it's not actually doing any harm. It's just the bacteria is simply there. However, when we do treat this asymptomatic bacteria, it means we're using antibiotics on something that doesn't actually need it. So I just wanted to give you that just as a little background and some context for the program that I'll be discussing. So now I'll spend some time walking you through the story of the evolution of our UTI program. And this will give me a chance to describe that unique methodology that we use to create it. The Infection Prevention Control Department at Public Health Ontario has devoted a lot of attention to this issue over the last few years. There's been a number of different initiatives that have collectively aimed to support stakeholders in long-term care homes to align to what is recommended as the best practices. So in brief, we had a number of inquiries. We had discussions with stakeholders that suggested that overuse of antibiotics for presumed UTIs was a really important area for us to focus on. We developed an innovation project that focused on this topic, and this supported a really comprehensive needs assessment that involved a survey to 380 staff in long-term care homes that had a role in assessment and management of UTIs. This was completed back in 2013, and it provided incredibly useful information on current practice and barriers to practice improvement. It was also noted through this survey that up to 80% of the long-term care home residents with asymptomatic bacteria were treated with antibiotics. So, of course, we recognized from this there was an issue, and we recognized some of the barriers from it. We also did a review of current evidence-based practices at that time, and we started to develop some resources that could translate these practice recommendations to the long-term care field. So we were on this path of creating resources to address the issue, but then took a pause to step back and decided that perhaps it was time to look at the issue in a different way. So we plugged in the lens of implementation science, and I'll describe what that is in a minute. And that way, what we wanted to focus on was developing a program, rather than just resources, that would impact behavior change. And this became that unique methodology. So now I'll sort of dive into what this looks like. But it's really important, before I orientate you to that, the development of the program, to just go back and define what an evidence-informed, theory-driven program is. So evidence-informed decision-making is, in public health, is a knowledge translation methodology that has become increasingly more common in program development over the last few years. And what we have learned is that evidence doesn't automatically diffuse or get taken up just because we've created it. We really do need to wrap it with some specific strategies. So implementation science is sort of a scientific subspecialty of knowledge translation, and it's really where we are practicing or putting getting right into the methods that would promote these research findings. So our IPAC department has been learning about implementation science and using it to develop our programs for the last few years. So it's really an exciting time to see how this is actually going into practice with it. So in the next few slides, I'll describe how the evidence was used not only for the selection of the practices that we want to have in our program, but also the selection of the program strategies that we would have within it, and how it's all come together. So for our purposes, we created an evidence-informed, theory-driven program and for long-term care homes that includes evidence-based practices that collectively address a problem, and that problem is that concern around the prescribing for presumed UTIs. And then it included implementation strategies that can be used to support those practices. And then surrounding the program are the supports that an intermediary like PHO could use to assist with implementation and how we could help the long-term care homes with this. So when it comes to designing the program, again, we just wanted to move away what we had traditionally done and what we were really familiar with, and make some more direct linkages to what those underlying problems were to actually making the practice changes occur in the home. So why is this type of program needed to support practice changes? It's just back to why don't we just simply do it? We know the evidence is to do this. Why don't we just go in and have it all happen? And we know that it's not just about having information and resources available. There's lots of factors that contribute to the practices that are taking place and move away from what's recommended best practice. So for this particular issue, some of the issues could be on the resident level even. We may have resident with communication difficulties, so it becomes really difficult to do an assessment. That process is much more challenging. We have families that may not know about antibiotic-related harms or how the diagnostic criteria for UTIs is actually written, and so there can be some pressure on prescribers to treat when maybe it's not the best or the right option. We may have organizations that don't have clear written policies to make sure that there is actually consistent practice in this area. And then sometimes we find that resident symptoms are not actually really clearly documented. So we have to almost go back and make sure that when we're looking at this issue that the information is written down somewhere in a really clear way and it's communicated to the prescribers. So we needed to shift our approach from just simple dissemination strategies because this is really a much more complex problem. And again, goes back to we want to impact behavior change. So we used a resource to develop this program that outlines 4 steps in developing an implementation program that would align really well with our approach. And we needed to add an extra step, that's at step 5, to reflect the role that PHO plays as an intermediary. So we're not the ones implementing, but the ones that are supporting the long-term care homes that will implement. And I'll walk you through the steps. So the first step to think about is to clearly identify who needs to do what differently. And I can't emphasize that enough. This is where we worked really hard to get a really good sense of the target audience, who it would be that we'd be focusing on making these behavior changes, and who would need to actually basically do this improvement if we were going to address this issue efficiently. And what should healthcare providers and the support staff in long-term care homes actually be doing differently? And really what we're looking at is what's the it that we're working towards. So this slide shows a really simplified logic model of what we were cut out to try to achieve and with whom. And so in this case, we want to decrease antibiotic-related harms in long-term care homes and engage prescribers, administrators, and frontline staff. So that's our who and our what. And we would do that by recommending strategies that increase capacity, opportunity, and motivation. So that's trying to get at that behavior with the goal of introducing these practice changes in the long-term care home setting. And so we know that the goal of this work is to decrease urine cultures and urinary antibiotics prescribed in the absence of indicated symptoms and signs of a UTI. And ultimately what we're trying to do is really decrease those antibiotic-related harms. So, in focusing on the it that we want it to achieve, the program development team narrowed it down to 5 evidence-based practices that could collectively help reduce the inappropriate use of antibiotics for asymptomatic bacteria. We drew on current best practice in the published literature, as well as that needs assessment that I had spoken about earlier, to help identify these priority areas. And we probably could have focused on 10 or 15 of them, and we probably could have focused on 2 of them. We landed on 5, where we thought we would have the most impact if we made changes in this area. So we identified them as 3 do's and 2 don'ts. And so the first there that I'll describe is a focus on obtaining urine cultures only when residents have been determined to have accepted clinical signs and symptoms of a UTI. So that's moving away from the non-specific symptoms driving urine culturing, which is often a big contributor to that asymptomatic bacteria treatment that we do. Another practice, obtaining urine cultures using proper technique to avoid contamination. This is a biggie because this includes that idea of use of a clean catch or midstream collection and an in or out catheterization. And this also involves storing urine specimens in a refrigerator if the transportation is not going to be immediate. Again, this would help eliminate those false positives or contamination. The third focus is on prescribing antibiotics only when clinical criteria for UTI are present. So we wanted to really incorporate that idea that you're reviewing and reassessing when urine culture and susceptibility results are received. So if antibiotics are started empirically, the physician or nurse practitioner, the prescriber, should reassess the need for it, still the choice of the antibiotic, and taking a look again at the duration of antibiotic therapy based on that culture and susceptibility report. The program also focuses on those 2 don'ts, and that could make a substantial impact if we focused on them for sure. And there's a focus on discontinuing the use of dipsticks to diagnose a UTI. And again, based on current recommendation, dipsticks aren't really a great diagnostic tool in this area. They lead to a lot of false positives, and that reinforces the practice that clinical symptoms of a UTI and a positive culture are required to make a proper UTI diagnosis. The final focus includes discontinuing routine urine screening at admission and annually, unless residents do have some clinical signs and symptoms of a UTI at that time. And so that routine urine screening is not currently recommended, and so this weekend we found was a really important area that we wanted to target with behavior change. So all of these are practice line with current recommendations, but published literature and the needs assessment have demonstrated there are a number of barriers in aligning with these best practices in the long-term care home setting. And this is why the next step in the process of building the program is really important. So we clarified our evidence-based practices, and then we needed to connect them with the strategies that would help the changes. And so you'll notice that this is connected by theory, and that's an important step we don't want to miss in this as well. So step 2 of our program development involved identifying and getting a better understanding of the barriers and enablers that are contributing to the current practice that's going on. And that's a step forward in better understanding the problems so that we can have more impactful strategies with dealing with them. So information on barriers and facilitators can come from lots of different sources. We could do surveys, interviews, we can look at the existing literature, and there's actually a lot of published literature on barriers and facilitators in changing healthcare provider practices. So what is recommended by this method of using this 4-step process is to categorize the barriers and enablers into common categories, and that's where our theory comes in. In this case, we use the theoretical domains framework. So the Theoretical Domains Framework, or TDF for short, is a really commonly cited theoretical framework in implementation science literature. It's been used extensively to understand barriers to clinical practice change and to develop interventions to address these barriers. So it's based on 33 behavior change theories that are embedded with this and grouped into 14 unique domains. And these domains can be used to classify the types of barriers and enablers that we're seeing that are relevant to this work. So we mapped out the barriers and enablers into the common domains that we found. So an example would be mapping all of our barriers from the survey that had to do with knowledge gaps. When we would hear back, oh, the resident's family are asking us to prescribe, we're just not sure they're getting it. If we heard, you know what, I don't think our staff understand this, that's another one we could map within knowledge. So there was numerous ones we could put in. We could even do under the skills one that's beside knowledge, there was maybe the staff don't know how to properly collect this, so that's an area. Maybe we need to teach that skill. So there were, of all this, it was a lot of sort of placing things into the proper categories and figuring out. So the orange shaded circles that I've got up here are the most relevant domains that we map the barriers and enablers from the information to. And so that was really helpful because now we could focus in on those orange ones to really look at what will be the strategies that we can pull that will have an impact here. So we moved forward and we organized our approach according to our theory. So the third step was identifying strategies that we could use to address these barriers. And there would be cases as well that we'd want to enhance the enablers we found because it's not all bad. Sometimes there's a lot going on that can actually help our cause. So we use something called the RX for Change Interventions database to pull the strategies from. And we also had to realistically really take a look at whether the strategies that we had chosen could be actually executed by long-term care homes. Would they have the resources available to deliver the strategies that we were recommending? And how would it really actually help with the problem and the issue if we were to recommend these strategies? So we had to make sure they aligned really well. So the strategies I have listed up here right now are the ones in the current iteration of the program. And I can say through evaluation, we went through several different versions of what the strategies would look like as we heard information back about what was impactful and what wasn't and where we could tweak things. So, and we also found that we would find more success if time was put into really assessing these barriers. So what we listed here is an overview of the strategies that we recommended. And so we have the strategies organized under 3 main headings. So we have the ones that are increasing buy-in and support. So those are where you're really looking at taking at the program to say, would this program be helpful in our home? Who would it be the person or people that will have the most influence to help us make some of these changes and to get buy-in within our home? And then also some strategies align under this that are helping to align with the policy and procedures to make sure that they actually are, so everybody's consistently practicing the same way and following the practice changes that are being recommended. And then we had to really look at how resident symptoms are being documented and to make sure that they are being communicated with the appropriate people, and in this case, the prescribers. So there's a whole bundle that fall under that heading. The other one was looking at increasing knowledge and developing skills, because again, back to the reference that we had mapped, that there was a lot of important areas here that we needed to look at. We knew that it was going to be essential that there was an element of being able to deliver education to the staff and making sure that there was a format and a way of being able to provide information and education to residents and families. And in that, there's a use of coaching, because we know we can do this, but we have to make sure we're always there sort of figuring out a way and helping people tailor and move forward with these different strategies. And then the third heading we have is monitoring the practice and giving feedback, because we really wanted to keep track of how things were going and to provide feedback when there was success and to provide feedback when there was room for improvement on it. And there's always reminders that are part of this as well. So there's a whole grouping, and what we then went on to develop are additional resources and tools that would be available to support the long-term care homes implement this program and these strategies. So for example, there are fact sheets, there's actually presentations that can be used for the education pieces, there's communication tools for residents and their families, there was a sample policy and procedure that can be used and guidelines about that. There's an algorithm for collecting urine and for when there could be how to assess a resident for a UTI. So this is all available of the packaging of the UTI program that can be found at our website at Public Health Ontario, as well as an implementation guide that pulls everything together, from that assessing readiness to actually participate in this, to looking at barriers, to also looking at the strategies, and then sort of connecting with the resources that would be best. So the result of using this approach to designing the program gave us our 5 practices. So you see those, and there are implementation strategies based on the barriers and enablers that we found. And they were linked by that theory so we could make sure that it all made sense in the end. And the important part is our practices and our strategies are all based on evidence. So we have a nice big picture to put together. So step 4 was where we needed to think about how behavior change can actually be measured and how we can tell if the program is actually having impact. So there's 2 ways to approach this. We can directly measure practice changes, such as decreased antibiotic prescribing, and then you can also look at the perceived gains in knowledge and how attitudes might have shifted within the home when the program is done. So I'm going to discuss our pilot and evaluation in just a couple of slides, but I wanted to just note that we were building evaluation in as the program was being developed. So there were lots of important lessons that we learned along the way during that program development. It's very important to establish the what and the who that we want to do as a result, and going back to what is the it that we want them to do. So what do we want people to do differently? And this is really critical for consensus, because in order to impact any sort of behavior change, we really have to be clear ourselves what we're working towards. And we also have to figure out that process of measurement, that part of how will we know if this practice is aligned and what are the areas that we're going to measure. So that was why it was really important to think about evaluation early on. What are we trying to achieve, and how are we going to measure if we got there? There's also great value in working with stakeholders to make sure that we're what they can and can't measure. So for example, long-term care homes, they helped us figure out the best sources of the data for this part, the lab reports and the pharmacy reports that we could use to calculate and look at the rates. Instead of us just arbitrarily deciding what we wanted to do and picking something maybe that would have been really difficult to access, which is not what we wanted to do, we were able to get informed from the actual people that are using and working on the ground level for what data could actually be pulled so that we could incorporate that into the measures that we would look at. And there's also a lot of value at looking at shorter term outcomes because again, behavior change takes a lot of time. So when you're looking at in the development stage, you need to really see, is there anything that's working really well? Are we on the right track at all? And we know that change takes time. So to look, you might want to look at targeted areas, for instance, just the knowledge piece of this working of this program. So there was lots there that we learned along the way as well. So from working through these 4 steps, our UTI program has emerged. So our project team looked at the evidence to see what best practices were for reducing unnecessary prescriptions for asymptomatic bacteria, and what should we recommend people do, what should people change to have an impact. We narrowed it down to those 5 practice changes that you see at the bottom of the screen, so the 3 do's and the 2 don'ts. And we recognize that practice change comes with barriers or challenges. And so we spoke with the field to try to understand when it comes to these practices, what's going to be a problem? And we heard about things like pressure from families, the culture for change, existing policies and procedures, staff turnover as well, because getting the momentum of a program going and then someone that's a key resource in it leaving could create difficulties as well. And that need for continued education and training among staff, along with guidance on how to use and incorporate the best practices. The strategies in the program were really selected to try to address those barriers and fell into those 3 buckets that I talked about earlier. And all were bundled into that implementation planning guide. And as well, there was also a key part to this that was really important. That was breaking it down into that assess, plan, and implement, sort of that review cycle of how to start with a program like this when you want to implement it. So that assess phase is really important. What do we want to improve? And are we ready to make the changes? And who should be involved? So important in it that it actually is a part that we really focus on for a long time. The planning part is, what are the barriers that we're going to anticipate happening? And then how do we tailor the strategies to address those barriers? And then the implement part of it all is really monitoring the changes and looking at the impact that might be taking place and starting to really look at how are we going to sustain this when you start to have success. So now that you have an idea of how the program was formed, I'm going to take some time to review the findings from a couple of the evaluations that we did to see how things were working. So we knew that if we were going to build an effective program, we needed to evaluate, and that's that formal process where we work with long-term care home staff and to make sure that we have input every step of the way. It also requires that we go into evaluation with a purpose. We don't want to just evaluate for the sake of evaluation. We want to make sure that we have processes in place so that we can actually take the findings and the learnings and apply them to the next version of our program. So we've done 2 phases of evaluation since the design and development of the program. In phase 1, we worked with 2 long-term care homes to verify and confirm those barriers and enablers that we were hearing back from the survey. And then we had to make sure that that aligned with the strategies that we had selected at that time and confirm that the implementation process that we were recommending actually made sense. And this was a great opportunity to actually get feedback from long-term care homes on the resources to support the changes, such as that algorithm and the educational tools. We wanted to make sure that we had what we needed and we weren't missing a lot or had gaps in it or there were areas that needed more clarification. So you can see from this slide, we consulted 2 homes with focus groups and interviews. And from this evaluation, we received 64 recommendations to support some sort of change within the program version at that time. So examples that happened where a new resource about delirium was developed in partnership with a nurse practitioner. We knew that we had to have some language and some tools and resources around that area. And there was also a planning tool that was found not to be useful at all. So that was scrapped and removed from the next iteration of the program. So that's just a couple of examples of those 64 that we really paid attention to and incorporated into our changes. The second phase of our evaluation wrapped up last year. So it was a really full evaluation with a lot of objectives in it. We wanted to really organize it around outcome process and a formative evaluation. So the outcome evaluation helped us measure whether or not we were seeing an impact. Did implementing this program actually result in a reduction in urine culturing? And did it result in reduction in antibiotic prescribing for UTIs. And like we said, we also wanted to learn about the program and the experience of the long-term care homes that were implementing it. So our process evaluation looked at how homes implemented the program and what the contextual factors that contributed to their experience along the way. And then there was a formative component. So we knew we needed to, in order to support the next round of what this might look like in helping people, we needed to find out the type of supports that long-term care homes needed, and then identify opportunities as well to improve any sort of usability of the resources that we offered through it. So there was a lot going on, and it took a while to do this actually. So we used a strategy to reach out to long-term care homes that would provide representation by region, type of home, and size. So we were looking at small, medium, and large homes. And we really relied on, in that recruitment phase to our pilot, looked at as existing relationships that our staff had in our IPAC department with long-term care homes. So we landed on recruiting 12 long-term care homes. However, we did lose 2 along the way due to some competing priorities and staff turnover that was occurring at the time. So we ended up pilot testing with 10 homes. And so we had homes commit to participating in 3 meetings with our staff, and that would be where our staff went directly into the home to actually support them through the implementation planning process of that assessment, planning, and then getting ready to implement. So all of the homes that were part of it received that implementation tool, the guide, and an implementation orientation and ongoing check-in. So we were really directly involved during this time to see because we really wanted to make sure that all of these aspects of our evaluation were going to be covered as well. So at the same time, data collection was ongoing. Homes sent us baseline data, so that we had 5 months of implementation planning, followed by 6 months of data. And that took place when there was actually the intervention taking place. And then the phase when the homes were independently off, doing their practice changes and strategies. So in total, we received 18 months of data. And at this time, interviews were also being conducted with long-term care home and PHO staff to understand what the homes had actually done, what had they implemented, and because we were really trying to do these interviews to collect what their feedback was on the process and receive those suggestions for improvement. And I've just included this slide to just show you a little snapshot of those 10 homes that were included, and I think there's actually the 12 are listed there. But this just shows the homes that piloted the program, and so that mix we had of nonprofit, private or corporation, and municipal council, as well as the mix of the sizes that were taking place, and because we really wanted to not just hear from one group, but from a variety. So we looked at how many strategies the 10 homes actually ended up implementing. And all the homes, when they were in their planning phase, had intentions to execute all 9 of the implementation strategies. So that at the time was the number that we were recommending. And what it ended up being is that 10 out of the 12 homes implemented at least 1 implementation strategy, and 3 of the homes implemented all of them. So it didn't end up being that everybody did everything, but the average level of adherence, or the average level of strategies implemented, were 6 out of the 9. And we found that the strategy that was around process surveillance and feedback were the ones that were not executed fully or not fully understood. So we knew we had to go back and do some more work on that area. And so what we learned from this, from the data collection and from the feedback that we were receiving, is that the program we had 10 long-term care homes contributing data, which showed that implementing some aspect of the program resulted in an average decline of 29% in urine culturing and an average rate of 42% decline in antibiotics commonly prescribed to treat UTIs. So, and we also found a total decline in antibiotic prescriptions by 27%. So we were thrilled by this because it actually showed even that we had some that didn't put a whole bunch of the strategies in place and some that put many more. It didn't matter because in an average we still had decline that was taking place. So we found that some strategies again, as I'd mentioned, were not as well understood as we had hoped. There were challenges integrating some strategies into practice, and again, there was a process surveillance form that we had recommended. It's a paper-based form that helps homes record the signs and symptoms of a UTI, because that was linking back to that barrier that sometimes things are not often written down or clearly communicated as it could be, so we thought we'd give this a shot. And what it ended up being is that it needed more work because sometimes it was too onerous to try to write on a paper-based form. We wanted to make sure that things were still within the chart and that we had, that there was enough there anyway that people could actually use it in a format that was relevant to them. And there was also time challenges for dedicated staff to see through the planning and implementation of the strategies. So we learned that that was really important too, and that would be a piece we'd have to really emphasize when we went forward with it to make sure that the path was cleared if an issue was identified. We had some promising feedback on aspects of practice from a qualitative point of view, and so we heard about how the program empowered frontline staff to improve practice, and we also heard that program strategies led to a very holistic view care of residents, and people were thrilled by that. And we also learned about how families were impressed with the program and took an interest in what it was all about. And we had one of our homes shared that following the orientation session at Family Council, they had the highest attendance they'd ever received on account of interest in this program. So we know that sort of confirmed to us in a lot of this qualitative feedback how important this program really was and this issue was. So we learned from the evaluation that we needed to improve some next steps, and so we spent some time on the last year working through a number of considerations. And so we simplified the description and organization of the strategies so that people could really look at them and they would find them much more user-friendly than maybe how we had listed them before. We improved options for resources to support process surveillance. We updated our UTI program implementation guide and our resources to reflect all the changes and recommendations that we had received. And important part was we had our stakeholder feedback, really informed all of the supports that we could use for scale up as we went forward. So I'll just flip through. These are just some of the resources that are available on our website. So just really quick screenshots of those just to give you a really quick idea of what they look like, those fact sheets and presentations that I'd mentioned. So where are we heading now? That's a really important question because we've finished our evaluation. We're feeling pretty good about the program. We know there's still certain areas we have our eye on that we want to make sure that we're doing well and we might be able to improve. So how do we increase our reach from 10 long-term care homes to a provincial scale-up of homes within Ontario that are interested and ready? So we are really looking at actually asking homes to examine whether they have an issue and then looking at if the timing, fit, and readiness is right for them. So scaling up, to use that term or to define that term for you, is really a deliberate effort to encourage long-term care homes to adopt the program and the practice changes by providing the tools and building capacity and supporting them as we can. So we decided to approach our provincial scale-up through a waved approach. So this means that what we're hoping to do is to support 25 to 50 long-term care homes from across the province right now, currently from May to October, move this program into their homes. And so some of our timelines have looked like what I have listed up here, updating our resources in our guidance document and assembling our own implementation team to be able to move and prep for the logistics and the internal training that we would need to be able to support the homes as we go forward. So we had a call for interest that went out in mid-April, and it went out to all of our long-term care home contacts in Ontario to participate in this. And we asked homes to take a look at that implementation guide and really focus on those reflection tools to consider whether they had an issue and whether the timing's right. And that's really important because there might be other priority pieces that are happening in the home at the time, and so while an issue might be identified, it may not be exactly the right time to go ahead. And the big piece was making sure there was human resources to dedicate this, so a lead and a co-lead as well that could actually cover off one another in pushing the program forward. So long-term care homes that are interested but not necessarily ready can still access the program on our website and then perhaps be ready to tackle it within subsequent waves or even maybe on their own. And long-term care homes that are ready have been signed up, and we have 10 we have five regional support teams that we have across our province, and we were able to accept up to 10 long-term care homes per region to get that sort of small group support. And so we were able to accept up to 50 homes, and all of that sign up has taken place. And so just to give you a real snapshot, because I know I'm running out of time, but a snapshot of what our supports look like is that we would have what we're calling learning collaborates, because we're sort of moving through a process together. So our regional representatives for each region would lead a learning collaborative where those 10 long-term care home leads and co-leads would attend. It's usually by webinar because of the spread out geography. And the regional reps act as coaches to help the leads understand the program material and understand the strategies and everything we've put together in that guide. And the big piece is that during these learning collaboratives, we really want to encourage sharing, because there's so many issues that are so common. And it's so nice to hear when that starts to work, that process where someone says, you know, we have a problem with X, and someone joins in and said, we had that problem too, and this is what we did to address it. So our role is to really facilitate those types of conversations. So the first learning collaborative is really focusing on that assessment and the planning phase of what are we going to try to achieve over these next 6 months and beyond. And then the second learning collaborative, we bring people back together to look at what are your barriers that you're identifying in your home, and how can we help you sort of tailor these strategies to make some sort of impact. And the third home then is where people are ready to launch and do the implementation, and then we talk a lot about sustainability planning and what we'll want to do. And what we're trying to do along the way is really learn how we can support this process, because it is different than what we did in the pilot where we were directly there. There's more layers now where we're actually supporting the leads to go back and do that implementation themselves. And what we're also doing is, again, looking at that to make sure that what we're doing is actually learning along the line as well. We're looking for those insights, and so we want to have that further understanding of the supports and structures that we're providing and any modifications we might need to do. And we also have those targeted resources and tools that we want to focus in and get feedback on as well. So it's been a really long journey, but it's been an exciting one as we move our program from one that we've created and evaluated and piloted to one that we're moving towards scale up of more homes being able to actively access it if they're ready and have an issue. And so we learned that to support improvement, you need a strategy that acknowledges barriers and enablers that influence the current practice. You need to tap into existing literature to assist with the development of these types of programs, because there's lots out there and lots to be learned. And an ongoing improvement process is critical to ensure that the programs are actually, and the resources are usable and supportive for those that are actually using them in the field. And the program encourages a lot of time in the assessment and planning phases before moving towards that implementation of strategies. So we actually needed to do that ourselves internally to make sure that we were ready to head towards provincial scale up. So we were really trying to practice what we've preached. And I think that was, I'd end it, sorry. But I've covered lots of information today, so I definitely encourage you to visit our PHO website under the UTI resources that are listed there to make yourself more familiar with what I'm talking about with the implementation guide and the support tools that are there. And I'd also like to just, again, acknowledge the PHO staff that have worked on this over the years, and the ones that are currently working on it and the ones that will be working on it as we go forward, as well as the long-term care homes that helped and the staff that helped pilot it and give us all that great feedback. It was really invaluable to that feedback into the current iteration that we have of the program right now. And that is it, and thank you.
Great job. Oh. Am I on? Can you hear me? Yeah. Thanks, Jill. That was great. We are running out of time. Do we have any questions from the webcast?
Not presently.
Okay. We can take one quick question. Well, we got two.
So do you have any recommendations where the biggest barrier that we face is we're northern and rural? So our turnaround time is 7+ days to get a culture back, and
Right.
most of our physicians are not willing to see the patient have a change of status, or then the family is extremely concerned. So do you have any recommendations about
Yeah,
that?
makes it such a complex issue, right? It's one of those ones, and I don't know. I'm going to turn to Anne, who was part of the earlier development. Did this come up as a common barrier that you ever ran into while you were part of that? Just the turnaround time for getting specimens back, and oh, you have a mic. That's even better. See, so okay.
Does it work? Oh, yeah, I think that is a common concern because the laboratories you're using, probably a private laboratory, so you do have a hard time with your turnaround time. And that's the one thing that then sadly that I don't know that this program is really able to address. That's maybe something that you could take to your laboratory and ask them how they can improve that service.
It's because we're located northern and rural, so
Yeah.
any results for any sort of cultures usually take about 7 to 10 days.
Right.
It doesn't matter what it is, and it's because we're 3 hours from the biggest major center that can do anything.
Right.
So that's where it's more of it's the transfer of the specimens that's the biggest issue that we can't control.
Yeah, so we really do want you to avoid taking those specimens if you can, and really focusing on the signs and symptoms of the patient to make sure that they actually do meet the case definition. That's one of those things about health equity, right? It's really challenging. Yeah.
Thank you.
So just really quickly, we used your program in Newfoundland. I have it piloted
okay.
in one. I have it rolled out to 7 more long-term care facilities, and it's working extremely well.
That's great.
We did 1 hour PowerPoint presentation with a pre-test, post-test with staff, and it was awesome. The one thing that was a flaw in our design, we looked at the one facility that was largest, that did the most urine culturing, and assumed everybody cultured urines, but we were wrong, and most people treated empirically. So one of the things I wonder why your UTI didn't come down as much for the CNS is, did you have more empirical treatment in the beginning that you didn't identify through your antibiotic review? Right, that's just
Right.
my comment.
Yeah,
That's
no,
one
that's
big flaw we found in our design, and then I had to go to a pre-post instead of
Okay.
comparison of 2 places.
And you have a poster as well here, right? Do
Yes,
you?
I
Yeah,
do.
so send everybody to your poster, because that's good too. Thank you for that comment.
So I'm Tanya, and our organization, we have 450 beds, and we implemented this program. And our largest challenge was our staff was referring to the algorithm for catheterized residents, so it put a
Right.
lot of people at risk as well. And we did have a few that we didn't pick up at, like quick enough. They were following that. So I'm wondering if you guys are looking at developing something that you could tackle
Yeah.
both at the same time.
Yeah, not at this point, but I
Okay.
didn't actually mention this, that the program that I was referring to is for
It's-
non-catheterized, medically stable residents. And yeah,
So-
so that is, there was a lot of other resources and tools. And I don't know, Anne, were you putting up your hand? No, I'm just wishful thinking there that you had something to add there. No, just that there was, so that is not anything at this moment that we are, because there are a lot of resources that are available for catheterization,
Yeah.
basically get the catheter out. So, but that is,
Yeah.
again, we have a very open mind to where we're going with things, and we know there's a lot of different barriers that are still being identified that we want to investigate going forward.
Yeah, we specifically made it for the non-catheter resident because there's the APAC document on catheterization, and so.
Right.
And that was the education we were trying to roll out, that people would refer to the same algorithm.
Oh, yeah.
It was just
Right.
residents at risk.
Okay, guys. As interesting as this could go on and on and
Yes,
on.
I'm happy to answer any questions, so I can stick around if
It's an
people have
area
any,
that's
or you're welcome
passionate
to email me.
To the IPAC world. Thanks, everyone, for your questions, and thanks again, Jill, for your presentation. It was great, as I say, it's excellent.